wonderful, amazing conversation. So Cindy Gamble, MPH-CLC, is Tlingit and of the Mansfoot clan. She currently works as a tribal community health consultant with the American Indian Health Commission for Washington State and is the project lead for the WIC and Nutrition Project, the Maternal and Infant Health and Maternal Mortality Listening Sessions projects. And she works collaboratively on many other AIHC projects. Cindy has worked with tribal health organizations and tribal communities in Alaska and Washington State for over 30 years as a tribal health director, a community health educator, and a tribal liaison for the University of Washington and Washington State University. Go Cougs. Cindy is currently the vice president of the Tukwakasut Earth Justice Board and the past president of Nutrition First. She's a volunteer and with the Canoe Journey Herbalists and is also currently enrolled in an Indigenous Herbalist Apprenticeship Program. Cindy has been married to her husband Jerry for 35 plus years. They have 3 adult children and 5 grandchildren. Again, Cindy, thank you so much for being here today. And Dr. Roberta Ward is Tlingit native from Southeast Alaska. Again, she is of Raven Moiety and the Humpy Salmon Clan and Moon House. Dr. Ward has worked as an RN for 14 years in a variety of settings. She then attended graduate school and obtained her certification for nurse midwifery, followed by her master's, FNP postgrad certificate, and finally doctorate of nursing practice. Dr. Ward has been caring for women for over 2 decades, and the majority of her work has been with Native American females in Alaska, Utah, and Arizona. Dr. Ward currently sits on the Arizona Maternal Mortality Board, and she is passionate to improve the healthcare of Native American women and men and their families. Dr. Ward currently lives in Phoenix, Arizona with her husband and granddaughter. She has 5 children and 7 grandchildren, most remaining in Alaska. So again, thank you so much for being here today. And let me stop my share. Okay, great, Roberta and Cindy. Hi, it's so wonderful to have you with us today. I guess if you want, you can introduce yourselves if you would like, or we can jump right into it with some questions.
Okay. Hi, everyone. This is Cindy. And Maddie, you took a lot of time with the bio already, but I just have to make a comment that this is amazing. I haven't met Dr. Ward before, and though you didn't intend it, in our culture, you have balance. You have an eagle and a raven here presenting today. So that just is kind of fun to me. So nice to meet you.
Nice to meet you too. I'm sure we have relatives in common. And I just had some smoked salmon from Yakutat on a bagel for lunch. So woo, I'm lucky. I was blessed.
You are.
Thank you for inviting us, Maddie. And it is kind of funny that Cindy and I have never met, because in Alaska, if you're Tlingit, you do definitely have shared family members. And just the fact that I've never considered myself any kind of an expert, but I have a lot of experience in different areas with both urban and rural Native Americans. And so some of the comments that were listed before were very interesting to me, because talking about Alaska Natives is talking about Asians. Okay, so how many different Asian populations do we have? It's the same with Native American. We have rural, we have urban, we have different tribes with very completely different practices and beliefs. So it is kind of hard to lump everybody in place. And then of course, nowadays, most of us, or many of us, are blended, either with more than one tribe, or for myself, I'm half Gusuk is one of the terms for white people. From Serbia and Ireland. So my other half is Tlingit. So anyway, it's very interesting how all those questions come together.
Yes, and I agree. Thank you so much for inviting us to be on this panel and speak today. Appreciate it.
Of course, and thank you so much. Yeah, I think that's great. The question around data and racial misclassification is a conversation that's going to be ever evolving as people, continue to, or our culture continues to evolve. One of the questions in, this panel is titled Current Tribal Representation on Existing State-Led MMRCs and What Can Be Done to Increase Tribal Representation. And then with the background that I gave on, working with the potential of a tribal-led MMRC, I wonder if you guys could kind of talk about what are some key benefits for creating tribal-specific and tribal-led MMRCs and how those would benefit maternal mortality prevention instead of maybe just a state-led or state representation.
Go ahead, Cindy. You start.
Okay, thank you. Well, I think that it's very exciting to consider having tribally led MMRCs. I think the work that I do with the American Indian Health Commission, and I apologize, in my bio, I did not put that I am a member of the Washington State Maternal Mortality Review Panel, and I have been on that panel for 5 or 6 years. But the work that I do with the American Indian Health Commission, we always talk about tribally led work and the importance of it. And we try to model everything that we do as being tribally led. And so it's very exciting to think of a tribally led MMRC and just to consider the process of building one from scratch. What would it look like? Not necessarily having to model it on the state-run MMRCs, but to really look at each community and the tribal cultural considerations that would be important in doing something like this, in reviewing a death of someone in our community, because that makes it very different, right? So I think that it would be it would be an exciting process. And exciting probably isn't the correct word when we're doing death reviews, but I think in creating these MMRCs in a way that is going to be most meaningful to each sovereign nation, each urban Indian community, to see how and what are the considerations, what are the issues. I mean, we are the experts in our historical experience, and you did a great job, Maddie, in going over these issues. So thank you very much. And so when we have our own MMRC, we don't have to do any explanations about all of those things. We come from a common understanding and a common place of knowing what we're going through today, the underfunding of IHS, all the historical issues that we contend with. And so instead of having the emphasis on what has happened, we can start looking at what can we do in the future. And I think that is really important. And with tribal MMRCs also, I would hope that we wouldn't have to contend with the trust issues. And again, because of all of our historical and current experiences, we have a lot of trust issues. And hopefully with tribally led MMRCs, we could be more open and trusting about the things that we would talk about and in our solutions. I think that would be really good. And let's see, I had some notes here, but I just think that the tribally led MMRC could be modeled and created in a way that will just be most culturally appropriate and respectful, and they don't all have to be the same. And I think that's an important point too. What do you think, Roberta?
A lot of things. One thing about a tribally led MMRC, things that I think about, if you just do one tribe for each one. The numbers, fortunately, are overall totally low. If you gather people together, that broadens the experience and answers and questions. One thing that a friend of mine had said, African Canadian friend, says is nothing about me without me. So I really like the idea that there would be more input from ethnically diverse population. I don't know that there wouldn't be as much, back and forth, because different tribes, if they were grouped together, think differently. But one of the things that I know there would be much less of, and one of the problems that I see, is the Eurocentric discussions and behaviors for most everything in our country still. I hope that it will eventually go away and we can become human-centric, but we still are looking at, white history as normal, and everything else as a variant to try to be like that, and I see that in the group that I sit on. Nothing meant negatively, but different viewpoints of, well, perhaps this person should be like, and no, we need to take people within the context of their own culture. You can listen to some different music by Native Americans, by Chicano, by Mexican Americans that discuss some of this, hey, this is my culture. What's wrong with this, and things like that. So that would be a huge benefit behind a Native-led or tribally led MMRC.
Great, thank you. That was a wonderful way to kick off this discussion. So I think when we're thinking about the uniqueness of developing a tribal-led MMRC, and again, there's none in existence as of right now. We're still working on what that would look like. Can you think of some key roles that absolutely must be included during a tribal MMRC formation that might not be included or usually included in state-based MMRC formation, or what you've seen that might be missing in your current in the current capacity that MMRCs are able to have?
I think we need IHS data. And Stacy Dawson, I saw your name on here. Maybe you can contribute to that discussion. We do not have IHS data, so and I'm not exactly sure why it has to do with tribal affiliations and tribal leaders and government leaders, but I think that's a big piece that's missing from the discussions for Native American. And also I think that we really need to include not just mortality, but morbidity. Women who are Native American who are dying from pregnancy, they're not dying from pregnancy. They're dying from things that started 20 years before their pregnancy, or they've continued 10 years after their pregnancies, before. Of course, we don't include those people, but we're seeing women dying of substance use. We're seeing people die of complications of hypertension. We're seeing people die of complications of diabetes. One way to reduce the pregnancy-related deaths is unfortunately good birth control, because women are getting pregnant whose health isn't maximized for a pregnancy. That would mean that people would actually plan pregnancies, and we know that at least half, if not many more, pregnant women didn't plan that pregnancy. We need more discussions around primary care. Okay, what are your thoughts? Do you want to become pregnant? What are you doing to prevent a pregnancy? We need more access to any different kind of substance use programs, whether it's inpatient, outpatient, online, anything, because when a woman or a man is ready to get clean, they need to be able to access some kind of care. And when we think a woman or man is ready to stop substance abusing or substance using, that might not be at the same time that they desire to do that. So helping prevent pregnancy in a forthright manner would be a very important aspect of the care of all of our people.
Yes, that is really good, Roberta. Thank you. When I think about the key roles that might be missing from a tribally led maternal mortality review committee, I just think of the especially the in-person reviews that we had in the state of Washington. And I always feel that even though we start out now with a land acknowledgement and a labor acknowledgement, which does put a different spin on it, I always feel like the need to start with prayer, just like we did in this meeting today. And especially when we are talking about something so sensitive and emotional as maternal deaths, I just think that there could be a different way of starting, to have some medicine or some ceremonial people there to start us off in a good way when we do these reviews. I think it would be very interesting to have elders be on the panel because of all their, of course, their years of knowledge of what has gone on in our community, and what has happened, what some of the resources such as Roberta and Indigenous midwives, what a difference that has made. You know, just the things that have gone on, the ups and downs of the community over time. So I think elders and CDC talked about the key informants, and I think that's really important. And so would it be helpful to have some community members there? I know in some of the reviews that we've done in the state of Washington, some of the members have really wanted, in specific cases, have wanted to hear from the family themselves. And so I think there are different ways of looking at who would be on the Maternal Mortality Review Committee, how it's formed, how it's conducted, how it's done, who is on it. And of course, when you're looking at a whole state's maternal deaths in a year, there's a lot of them. And many different people are represented. And so the issue with it is time, of course, the time it would take to do an in-depth review in this manner, and to do these things, you know, to be able to smudge off before and especially after, at the end of the day. Things like that have meaning and help protect our mental and emotional health of the people who are part of the committee also. So those are things that don't happen now. And I'm sure that each community would have their own ideas of what is important for them and what are important committee members that they would like to see in their committee, but to be open to who that they might be, that it is more, we need definitely the clinical folks. But in the state of Washington, when I first started, we were highly represented by clinical folks, by OBs, by the coroners, by mental health practitioners. And in this last review we not only looked at the review from a clinical perspective, but we are now looking at it from the social determinants of health perspective too, because that is where we are really going to make a lot of difference also. And so I think expanding it and having the time to do it will be key to really making a difference in reducing the maternal deaths and the disparities. Thank you.
Thanks, Cindy.
Yeah, I just wanted to read out a couple of the comments that are in the chat for you guys. Excuse me, Teresa said that tribally led MMRCs are a must. Who and what we look for when reviewing data come from our core beliefs and history, and that will reflect on goals. Janelle, in all caps, said, thank you, Roberta. Yes, we need IHS data and timely data. Sally agreed, yes, we need IHS data. Tribal epidemiology centers are seeking the federal and state data that we all need through congressional hearings, continued policy advocacy. Janelle again also said ACEs are being rolled out across the country and recognized going forward. We have screening tools, etc., but these issues have been happening for a very long time, and there's still a separation in data of this and pregnancy-related deaths. Can Sally again reaffirmed access to substance abuse treatment? Marina said, thank you, Cindy. Charlene, prayer is important. Teresa, all healing must involve spiritual modalities. And then loved hearing, looking at it from social determinants of health perspective. This changes our understanding of prevention so much. So those are some feedback that we're getting in the chat. So let's see.
Now you've met my husband.
What are some key questions that tribes or tribal organizations interested in serving on or establishing a tribal-led MMRC should consider? And what are some key things that you've learned in serving your time on as a tribal representative on a state-led MMRC?
I'll start. So, again, it depends on where the tribally led MMRC is going to be based. I think you need to make sure that it's balanced well with both urban and rural components, because people who live in town have different habits and oftentimes different beliefs than people who live in a more rural area. Different states, for instance, from Alaska, when we say rural, we mean rural. You can't even drive to the small communities in Alaska, you must fly. And to get a pregnant patient, a pregnant female out of the state of Alaska or out of the small village to the tertiary care center in Anchorage is, a long period of time where an ambulance, first of all, you have to maybe even get that person in from the village to the hub community, call Anchorage, get a plane from Anchorage to that hub community, and then back down. So we're talking 6 to 8 hours. So we definitely need input from those practitioners. And I worked in Kotzebue most recently in Alaska, and it was all midwives. So raw, big hands up to the midwifery groups out there. And then, for instance, in Arizona, it's a very big, broad state. We have a lot of urban natives here in Phoenix and in Tucson, but we have a lot of people living on the Apache reservation or the Navajo reservation, who again have different lifestyles, maybe more traditional viewpoints, but also have poor access to care. Not that they don't have care there, but the hospital might be, again, 3 hours away, at least by road, but it takes a while, and then the person may or may not have cell access. So there's a lot of different things to consider just for those types of things, or where people are located, and what can be done. Having I like the idea of spirituality being on the meeting, but I would be very cautious of having different tribal, leaders, because I'd like to see people from the community, clinicians, different people like that, EMTs, that can really say, hey, this could have been done better, that could have been done better, and try to, keep politics out. I'm done.
Okay. Those are very wise words, Roberta. And you are so lucky to be able to work with all of those Indigenous midwives. That's pretty amazing.
I have been lucky.
Yeah. So again, I'm going to be repeating myself a little bit, I guess, in that I think in beginning, it's a very important thing to consider of establishing a tribally led maternal mortality review committee. But when thinking about it, I think the philosophy and the approach in starting from scratch, I mean, if they want to, maybe they want to model it after a state-led and just go into how things are done on that level. But I think it's an amazing opportunity to look at things from a different way. And I loved, Maddie, when you talked about the issues of protective factors and our strengths. And I think that this is an opportunity to try to look at things more broadly too, when we're establishing our maternal mortality review committees. So start it from scratch, decide what the best way is to conduct the reviews, what things from our culture, what do the elders think, and how can we bring that community value of the importance of mothers, you know, of the sacred responsibility and trust of bringing new life into the world. How do we bring that back into a community priority, and where people see their piece in taking care of mothers and babies, that we don't put all the responsibility into the four walls of the clinic, you know, because we've seen that data that says how much of good health comes from the four walls of the clinic or the hospital, and how much is actually in what happens in our lives and in our community. So I think that's an opportunity of how can we look at those things, bring those things into the review to make sure that those things are going to be considered. I've already said that I really think that the review should be conducted with prayer and emotional support. I think that's really important. We have to have an emphasis of looking at the issues of hysterical trauma and the social determinants of health and what to do about that. But then just basically, some of the questions would be, how often would you conduct a review? How confidentiality and privacy will be addressed? Will it be a single tribe? Do they think it's better to form some sort of consortium? And how would that happen? How will the reviews be structured? Who will be on the committee? And really, what is the purpose of the review? Why do we want to do this our own way? Do we want to look at only deaths, or do we really want to look at maternal health? And how do we keep our mothers healthy? Because I think we really just have to look at the systemic issues and put a lot more priority on what it is that Roberta mentioned morbidity too. I believe it's really important to not only look at mortality, but morbidity also. And we can't just do that by looking at the clinical perspective. There has to be a really strong examination of the systemic issues that have been discussed earlier. So thank you.
One of the things that, so you were talking about the value of working with Indigenous midwives. In the settings with which I work, in hospital settings, when I was catching babies, there are very, very few Indigenous midwives. So going some more Indigenous midwives to work in that arena would be great. There's, you know, home births, there's hospital births. The hospital births tend to have a higher morbidity and mortality because women who prepare for a home birth generally have a certain thought process and way of caring for themselves that is not necessarily shared with all birthing women. So kudos to those women.
you know, but yes, morbidity comes first. Mortality is a result of morbidity. So we need to start way before all life starts with birth. And there's just so many, it's overwhelming to me to think about this, because being on a committee, we can say, oh yeah, that happened. But the next step is, what are we going to do to help people? And when I say help people, I mean, we need to help dads, we need to help moms, we need to help the children. No change is going to come just by looking at one instance. You have to go and look at what led up to that. So that's really important. And our nurse extractors, and pardon me, Kate, if I'm saying it wrong, Kate was one with the MMRC before, but did an excellent job of collecting data. Martin is on here too, and he can attest to that, as far as collecting it from some people, from family members were included, police reports, hospital reports, all of that different information. But the next step is, okay, what are we going to do with this data? And the same thing would be occurring for a tribal MMRC. What can we do to make changes? They're not simple fixes, they're not quick fixes, but we have to start somewhere.
Yeah, thank you. I think those are some great topics to start with. And yes, where do we start when the topic is so all-encompassing? So someone did note that with the intersection of maternal mortality and MMIWG expanding into living accounts, morbidities, and survivors would be essential, since not all deaths are likely being captured. Thank you, Kate. And just again, thank you. You're getting comments, Cindy. Thank you for your thoughtfulness. And Roberta, thank you for your thoughtfulness. Let's protect our experiences, which increases resiliency. I just one more question before I kind of open it up to the floor. This is also, you know, MMRCs, or a tribal-led MMRC, is just one tool in overall maternal mortality prevention or maternal health promotion. What, in addition to MMRCs, is needed to prevent maternal deaths and support Native maternal health? And how can we uplift the strengths of tribal communities to support this work? I feel like this is a very loaded question, and there's a lot of answers to this, but just what do you think? What are your thoughts?
Yeah, this is a very complicated question for sure. But I think that I touched on a little bit in the last answer, and that is maternal and infant health needs to go back to the priority that it should be. And you know, we live in a nation which is sometimes referred to as the most powerful nation in the world, and yet I think everyone on the call knows how poor our maternal and infant mortality statistics rank compared to other so-called developed nations in the world. And so this is how things are in the United States. And this isn't how it was in our traditional nations pre-contact. You know, we had the sacred obligation and respect for the women and to take care of them. They're the next generation, our children, are so important to us. And so I think we just need to bring that into the priority that it should be. How can a nation go on if we don't have strong women and children in the next generation? You know, it just has to be. So I think more attention to just overall maternal health, not just the focus on mortality. We really need to look at, and maternal health doesn't start when a woman becomes pregnant. You know, the maternal health, I mean, we could say it does start at birth. The health of that woman that person starts at birth. And there are so many things that go into it, into having a childhood that is well supported and learn how to express emotion and is well loved and free to develop their own strengths that they have to talk to women. I mean, when we used to have, when a woman had her first moon, and they had all the time with their mom and aunties and the elder women of the tribe to learn those things. I mean, that is precious. That is important, those milestones of learning those things, and how to take care of yourself, nutrition. So all of those things feed into being a healthy woman, a healthy person who is going to become a pregnant and parenting person. And so the emphasis on maternal, I mean, it's very widespread. It's not even in the perinatal period. It's a very long period. And I think we have to put it in context of what it takes. And again, we have to go back to healing from our historical experiences, of healing from all of the poor nutrition that we had from boarding school, from commodity foods, from having to be on reservations and not being able to feed ourselves and gather medicines, getting back to our traditional medicines and the practices, like Roberta said, with Indigenous midwives, that those things are really important. And without tribally led MMRCs, these things may not come back, because I don't know if you were cautioned by your elders like I was, but you don't talk about these things in mixed company. You don't necessarily talk about our traditional practices and our traditional medicines because of cultural appropriation. And so we are protective of those things. And so the result of that is that it's not as widely used as it could be, or supported, or known. And so we have to connect with those things. So I just think that when we talk about the social determinants of health too, there's talk and then there's walk, and there's just not a lot of walk about full funding for IHS, for the food security, all the things that you brought up, Maddie. You know, we need funding for those things. We need funding for Indigenous midwives. We need that to be promoted. We need birth centers. Not everything needs to be a hospital birth or a home birth, but we could have birth centers. Where's the funding for that? And then just for doula type supports, for more public health interventions, family health interventions in our communities, of doing family life education. There's just, we have a lot of needs, and if we really want to improve, lift up maternal health, we have to look at all of those things and not just looking at deaths. Thank you.
Thanks, Cindy. I totally agree with you. Yes, we want to look at the reason people die around childbirth, but that is just the very unfortunate tip of the iceberg, when really, if you want to make changes, it has to be done well before birth. And when I say life starts at conception, and that whole time when that baby's going inside mom, you know, everything that she does or is around affects the unborn. I mean, I've talked to babies in utero, they can hear you, they respond. And the importance of the family support system, whether it is, you know, grandma or a male partner or female partner, those things really need to be taken into account. So it's much more complicated than just counting the numbers of women who die, or birthing people, I'm not used to that term yet, birthing people who die around, you know, childbirth. It goes way more deeper. Someone mentioned ACEs, but for my population that I work with currently, there isn't anyone who doesn't have, you know, some ACEs who affect their lives and their upbringing. So I guess, you know, that's why I think morbidity needs to be included in this, not just maternal mortality, but maternal mortality and morbidity, to kind of get an eye on what different things can change. Just food deserts, you know, some of the places that I worked on the Navajo reservation, you know, the gas station's 30 miles away. Now gas is down here in Phoenix is almost $5 a gallon. Up there, it's probably $6 or $7 a gallon to just get to where you can get fresh fruits and vegetables. Some people do bring them into the community, and I think that's awesome. They still, you know, honor hunting and the gathering of, you know, keeping herds of sheep, different things like that. That's really important. And that would be an urban, I mean, a rural importance. Urban may be completely different because there's grocery stores aplenty, but a person may not have even, maybe not even the knowledge to understand what would be a good good things to eat during pregnancy, or the means to purchase that. Definitely substance use has impacted our nations heavily, even in the little tiny villages in Alaska. There's methamphetamine. Convincing people not to use that, and helping recover people from the use of that, I think, is the underlying issue there. You think it wouldn't be flown into little places, but it is. Anyway, I ramble a lot, sorry. Any questions?
Yeah, I want to open it up to wrap this panel up with about 15 minutes left. You can use your raise hand function, and we can feel free to comment as you'd like.
I see a comment. It says, Hannah says she feels like Medicaid coverage for birth and postpartum doula care would go such a long way. The population that I work with has access to care and has a lot of coverage for Medicaid. Postpartum doulas, not so much. That would be a great addition.
Mr. Barton, if you'd like to unmute yourself and ask your question.
Yes, good afternoon. Nick Barton here. There's my video. Roberta, Cindy, thank you so much for sharing that. And to the people on the call, forgive me for just asking these questions. But I wanted to share with the panel that I'm Cheyenne Arapaho, and I'm the executive director for the Southern Plains Tribal Health Board in the Oklahoma City area. And I serve on the state MMRC, and I can certainly empathize, sympathize, and right there with you in serving with the state MMRCs. And ours was just in the state, ours was just created in 2019, and it's still growing, but it's more focused on, I think, clinical and the mortality. And that was attending a first meeting was very rough. And I think as time grows, and I think that's going to be the beauty of tribally led MMRCs, is you get to look and make it your own and look at the mortality and address the social determinants of health. And I think that is where, at least in the Oklahoma State MMRC, that it is growing into. There still has to be some education, at least here in Oklahoma. Ours is codified in law, and there's a 25-member panel, and one is set aside for Native Americans, specifically the director of our health board. And so that's kind of our saving grace. And I know that was done through education and advocacy, but it's still I think there's still some trust issues, at least on the state side and tribal side. So one thing we found going through was getting information from some of our tribal healthcare providers. The nurse case extractors had some difficulty, and I go back to that slide that Toby had put up, and we're always cautious about research, but this is not a research project, and so I think I'd just like to hear if y'all have any other challenges that you face on your state MMRCs. Thank you.
This is Roberta. Our MMRC, they work really hard and they try really hard, and I think that we do look at a lot of different, we go back and forth and discuss things like racial discrimination, just plain old discrimination, because it's not always racial. We have discrimination towards obese people. We have discrimination towards substance using people, and these can definitely affect the care. They do affect the care along the way. So our MMRC here in Phoenix works really hard to try to get to that middle point. I think that's important things to discuss, and remembering that not all discrimination has to do with where you live or the color of your skin, but there's other forms of discrimination that are definitely affecting our persons. And then also, I really think it's important to find a way to support the family members and the men in all of this, because families, you have to support the whole thing to help improve the healthcare going forward.
And yeah, thanks for sharing, Nick. That was good. I'm glad you're on your state MMRC too. In the state of Washington, they are really working hard to improve the process and really get to the point where we can make good recommendations that are going to make a difference in the rate of maternal mortality. The first review I was on, with your first year, it's a bit overwhelming. But what I most remember is we looked at the pregnancy associated and pregnancy related, and then went through the process of MRIA form and recommendations and et cetera. And then the next year, they added suicide and overdose deaths, which was very different, right? And so then your recommendations and your scope is very different. And then I think the year after that is when the MRIA form changed, and they added discrimination as an option to choose. And so again, there it broadened, and we were able to make recommendations that were more meaningful to us and more pertinent for us, and not just us, but everybody, I think. And then this past year, our review, as I've already said, we looked at things and asked the questions in the MRIA form, not only from the clinical perspective, but also from the social determinants of health perspective for all of our recommendations, to make sure that we were capturing as broad of recommendations as we can. And I just think that representation is just so important. And we need the clinical people. We need to understand, Maddie or someone said that hemorrhage was the #1 cause of maternal death. Of course, we need to have the clinical perspective on that. And there has just been, I'm not a clinician. And so the discussions are very, very interesting. But we also need the discrimination and social determinants of health perspective. Again, if we are really going to make a difference, those have to be included in the recommendations that then in Washington goes to the legislature for their review. That is part of Washington law also. And so those are the things, you know, that's where the money needs to go, the funding and resources need to go to really understand what is going to make a difference. Just understanding. So anyhow, yeah, we've already hashed that. So I think in our state, that's the thing. It's just hard to get, I think one of the things is it's hard to get the full representation from all of the groups that you need. Like one of the groups that has high disparities in our state, I don't think we have one panel member who represents that group. And I think they need to be there at the table too.
Thanks,
For your
Cindy.
question.
I think it's definitely important to include community members and non-clinicians because you get a different viewpoint. For those of you who are not clinicians, there are things called bundles. Let's see, I always have to look up what each acronym stands for, but AIM, the Alliance for Innovation on Maternal Health, is putting forth community care initiative bundles. That means, so a bundle is things that you do to care for a certain person, you know, in or out of the hospital. I think the hospital bundles have done a really good job making it so women do not die of hemorrhage in the hospital. Women do not die as much, I guess I should say, of preeclampsia. And so now we're seeing other social determinants of health. The clinical care or community care initiatives are going to be meant to be put forth in clinic settings. Again, to start before the ball starts rolling quite as fast into improving health. So that's important. Thanks, Maddie, for putting that on there. But just my emphasis is on that there's going to be some community care bundles that will start in the prenatal time period instead of at the delivery time period.
Oh, go ahead, Dina.
I have a question. If others in the group are still thinking of theirs, for Cindy and Roberta, I'm curious if you can share a little bit more just from your experiences working with the state MMRCs and thinking as, you know, potentially transitioning and supporting to tribal-led MMRCs or some other tribally focused formation. What resources have you seen be real helpful to establishing those or continuing them? You know, funding, time, money, training, all of those sorts of resources, and, you know, kind of onto that, who should be providing those?
That's a good question. In Arizona, I think we're still in the talking stages of, you know, looking and delving into the reasons behind the deaths. Yeah, I did put the link for the most recent report, and so I think that this has only been, I've been involved for about 2 years now, I think, and I think the board has only been around for maybe 4 or 5 years. I'm not exactly sure how long, but you know, there's a catch-up time period, and I think that's common for many places in the country, is that there's this catch-up time period going on, and now we need to know what to do with that data. How can we, you know, how can we change that? So different support systems would be making sure that there's food available, making sure that there's, from the state or the federal side, that there's substance use treatment programs, both inpatient and outpatient. I know that there, you know, we do have a few inpatient treatment programs, but a mom who's raising 3 kids and suffering from a substance use disorder is not going to want to go and stay for 30 days in a place where she cannot take her children. Some people have partners and family members who can help out with care of the children during that time, some don't. So I think that's a huge one right there. Again, support for men, however, whether it's tribally led support, federal, state, you know, I think there's a lot of potential resources for putting forth things, and some things that are happening, but that can improve. And there's a lot of bills that are currently being passed nation, in the nation's capital, which I cannot speak to. I look at them and I don't remember all of what it says, but there's a lot of things in progress right now. I think we're just sort of on the teeter-totter part of putting some of those support systems in place. And it's a long haul. It's not short and easy. So,
boy, that's for sure, Roberta. It's going to take a while. But yeah, that's a really big question, Nina, because of course I would say the federal government has that responsibility of taking care of the needs of American Indian, Alaska Native people. But of course, we know that IHS is what, funded at 39% of need now. So that is not, they're not doing a good job at that. But the primary responsibility, I think, does lie there. If we see that tribally led MMRCs are going to be a best practice and of course I'm making a huge assumption here, but are promising practice, let's say, in dealing, in working to improve maternal mortality, decrease maternal mortality of American Indian, Alaska Native people, there needs to be funding. And this just brings up a whole different issue. When I was a health director in Alaska, I know that they talked about relative value units, paying people in rural Alaska at a different rate, a reimbursement rate, because it costs more to provide service there. And that is really true, not just in Alaska, but in many of our communities, because they are rural. And again, all of the things that were laid out in prior presentations today. But I think one of the biggest issues is that the funding is still being looked at from an equality lens. And if we really want to make a difference in disparities, reduce disparities, and improve the health of some of these groups, especially ours, we need to look at funding from an equity lens. So who are other partners that we can bring in on this? And when I say equity lens, I mean, what I mean is, plain speaking, is that we need more money to make a dent in the disparities. If we continue to get, even if we had level funding, if IHS was fully funded, that would really help, but that's fully funded. I think we even need more funding than that because we have so much catch up to do. We have so many years of healing to do, so many years of discrimination and trauma to undo. It is going to take more resources. So can we find partners to help with this? I mean, I would hope so. In this environment and climate today of not only the COVID pandemic, as people said, but the racism pandemic, you know, there's a lot of attention. So maybe there is good timing to try to find partners who could work with us on long-term investments. We couldn't just have a 3-year, 1, 2, 3-year grant to do this. We would have to have something like at least 10 years of assured funding to set up MMRCs, to really set them up to succeed and to really see what impact they would have in our communities. Can you tell I'm an idealist and I haven't given up hope? I have a lot of white hair, but I still haven't given up hope that you know, things are going to change, and they are going to change for the better, but we are going to be a part of that. Of course, we have to be a part of making the changes happen.
Thanks, Cindy.
Wow. Thank you so much. I get emotional. It's awesome to hear from you too, and thank you both for sharing your expertise through this panel, and hopefully we can continue